In this video, we'll be going to discuss about the kinetics and kinematics of the lumbar spine. So coming to the structure of the lumbar region, so similarly to the other structures, other regions, you can able to see the typical as well as your atypical vertebrae. The first four lumbar vertebrae are similar in structure and therefore they are known as typical lumbar vertebrae. And the fifth vertebra has a transitional property or transitional function. That is why it is atypical in structure. So therefore the fifth lumbar vertebrae or L5 is atypical in structure. So coming to the typical lumbar vertebrae, the body of the typical lumbar vertebrae is massive, have a transverse diameter that is greater than the anteroposterior diameter and greater than the height. The size and shape reflect the need to support greater compressive loads caused by the body weight, ground reaction forces, and muscle contraction. The pedicles are short and thick and they are projecting posterolaterally. So the pedicles in the lumbar vertebrae is short and thick as well as they are facing posterolaterally. And coming to the laminae are short and broad in the lumbar vertebrae. So coming to the psychopophyseal articular processes, both the superior and inferior facets vary considerably in shape and orientations. So the mammillary process, which appears as a small bumps, are located on the posterior edge of each superior psychopophyseal facet. So mammillary process, like your uncinate process or demi-facets, which is a unique properties or unique feature of your thoracic as well as cervical vertebrae, there is some unique feature or unique process that is known as your mammillary process that is present over your lumbar vertebrae. So mammillary process, which is situated on the posterior edge of the superior articular facets. These processes serves an attachment sites for the multifidus and the medial intertransverse muscles. The main function of this mammillary process is for the attachment for your muscles such as your multifidus and medial intertransverse muscles. The superior faces are vertical and concave and face slightly posteriorly and medially. So the orientation of superior facet is in the posteriorly and medially, and these facets are vertical in alignment and concave in shape. The inferior facets are also vertical in alignment and they are convex. So the superior facets are concave and the inferior facets are convex. And the inferior facets are slightly facing anterolaterally. So superior facets are facing posteromedially and the inferior facets are facing anterolaterally in order to for the proper articulations. So this is the superior articular facet and this is the inferior articular facets. The superior articular facet will be facing posteriorly and medially, and the inferior articular faces will be facing anteriorly and laterally. And the superior facets and inferior facets, both the faces will be vertical in alignment, and the superior facet will be concave in shape and the inferior facet will be convex in shape. And these are the process. This is the superior view. In this you can able to see the vertebral foramen, spinous process and all. And the mammillary process. So mammillary process is present over the posterior aspect of your superior articular process. So this is mammillary process is one of the unique feature for your lumbar spine, and this mammillary process serves an attachment for your muscles. So mainly your medial intertransverse muscle as well as your multifidus muscle. So coming to the transverse process, the transverse process is long and slender and they will be extending horizontally. And in the transverse process, one more unique feature like your mammillary process, that is your accessory process, which has small irregular bony prominence and located on the posterior surface of each transverse process near its attachment to the pedicle. So the axillary process is one of the unique feature present in the lumbar spine that is located on the posterior surface of each transverse process near its attachment to the pedicles. The accessory process also serves an attachment sites for your multifidus and medial intertransverse muscles like your mammillary process. Both your mammillary processes and your accessory process serves an attachment site for your multifidus and medial intertransverse muscles. So coming to the spinous process, the spinous process is broad and thick and extends horizontally. The spinous process of the lumbar spine is broad and thick and they will be extending horizontally. And coming to the vertebral foramen is triangular and larger than the thoracic vertebral foramen but smaller than the cervical vertebral foramen. So coming to the vertebral foramen, the main feature is they are triangular in shape and they are larger than the thoracic spine but smaller than the cervical spine in diameter. The diameter will be larger in the thoracic vertebrae and smaller than the cervical vertebrae. So this is the spinous process. The spinous process you can able to see here. It is broad and thick and they will be extending horizontally, and the vertebral foramen. So the vertebral foramen of the lumbar spine will be triangular and they will be larger than the thoracic vertebral foramen and they will be smaller than the cervical vertebral foramen. So in essence we can able to say that the cervical vertebral foramen will be larger in diameter comparing to the thoracic as well as your lumbar vertebral foramen. And in this transverse process in the posterior aspect, you can able to see one processes or one unique feature that is known as your accessory processes. So here you can able to see this is the transverse process, and the posterior aspect you can see the accessory process, and this is the superior articular facet. In the posterior edge you can able to see the mammillary process. So both mammillary process and your accessory process are a unique feature in the typical lumbar vertebrae that serves as an attachment for your multifidus as well as your medial intertransverse muscles. And next, coming to the atypical vertebrae, that is the transitional vertebrae, that is your fifth lumbar vertebrae. So fifth lumbar vertebrae is a transitional vertebrae and differs from the rest of the lumbar vertebrae in that it has a wedge-shaped body whose anterior portion is of greater height than the posterior portion. The L5-S1 lumbosacral disc also is wedge-shaped. The superior discal surface area of the L5 is about 5% greater than the areas of disc at the L3 and L4. The inferior discal surface of L5 is smaller than the discal surface area at the other lumbar levels. The spinous process is smaller than the other lumbar spinous process, and the transverse process are large and directed superiorly and posteriorly. So the transverse process are large and they are directed superiorly and posteriorly in the L5 vertebrae, but in the L1 to L4, that is the typical vertebrae, it will be extending horizontally. So that's the difference between the typical transverse process of your typical vertebrae as well as the atypical vertebrae. That is atypical, that is your fifth lumbar vertebrae. The lumbosacral articulation is formed by the fifth lumbar vertebrae and the first sacral segments. The first sacral segment, which is inclined slightly anteriorly and inferiorly, forms an angle with the horizontal called as lumbosacral angle. So the spinous process, there will be an articulation formed by the L5, that is the fifth lumbar vertebrae, and the first sacral segment. In this first sacral segment, that will be horizontally inclined in a anteriorly and inferior manner. So that will be forming an angle that is known as your lumbosacral angle. The size of the angle varies with the position of the pelvis and affects the superimposed lumbar curvature. An increase in this lumbosacral angle will result in an increase in lordosis of the lumbar curve and will increase the amount of shearing stresses at the lumbosacral angle. So if the lumbosacral angle is increased, so this angle is increased means there will be an increase in the lumbar curvature, that is known as hyperlordosis or increase in the lordotic curve. So because of this increase in the lordotic curve, there may be an increased amount of shearing stress that is present over your lumbosacral joint. So increase in the angle may lead to increased shearing stress at the lumbosacral joint. So this is the lumbosacral angle. So this is, you can able to see the inclination of the sacral bone on the fifth lumbar vertebrae. So this inclination forms an angle that is known as lumbosacral angle, and the normal angle is around 30 to 35 degrees. Coming to the intervertebral disc, the intervertebral disc of lumbar region differ from other region. The collagen fibers of the annulus fibrosus are arranged in sheets called as lamellae. The lamellae are arranged in concentric rings that surround the nucleus. Collagen fibers in adjacent rings are oriented in opposite directions and 120 degrees to each other. The advantages of varying fiber orientation by layer is that the annulus fibrosus is able to resist the tensile forces nearly in all directions. The main function of this particular arrangement is that the annulus fibrosus can be able to resist the tensile forces in nearly all the directions. The shape of each disc is not purely elliptical but is concave posteriorly. So this provides a greater cross-sectional area of the annulus fibrosus posteriorly and thus increases the ability to resist the tension that occurs here with forward bending. So this is the representation of your intervertebral disc. In this you can able to see the annulus fibrosus arranged in a layer-like structure, that is the lamellae. So lamellae will be oriented around 120 degree each other, 120 degree. So because of this arrangement, the annulus fibrosus can able to resist the tensile forces in all the directions because of this particular alignment or orientation of the annulus fibrosus. So this is lamellar. This is arranged in the annulus fibrosus arranged in a sheet-like structure, that is your lamellae. So coming to the articulations, there are two articulations like other joints, other regions like your thoracic as well as your cervical vertebrae. They are the interbody joints and the zygapophyseal or apophyseal joints, otherwise known as facetal joints. So coming to the interbody joints of the lumbar region are capable of translations and tilts in all directions. And next is your apophyseal joints. They are true synovial joints and contain fibroadipose meniscoid structures. These joint capsules are more lax than those in the thoracic region, but more tight or taut than those in the cervical region. The joint capsules in the lumbar region will be more lax than in the thoracic region, but they are more tighter or taut than in the cervical region. The dorsal capsule has been demonstrated to be fibrocartilaginous, which suggests that this portion of the capsule is subjected to compressive as well as tensile forces. In a newborn, the facetal joints in the lumbar region lie predominantly in the frontal plane in the presence of lumbar kyphosis. As the child develops and assumes an upright posture, the curve of the lumbar region changes to lordosis and the orientation of these facet joints changes as well. So in the newborn, because of the increased concave, there will be an arch-like structure, so it will be in this manner. So because of this, lumbar spine is also in a kyphotic manner. And because of this kyphosis or lumbar kyphosis, there will be alignment of this orientation of this facet will be in the frontal plane. And once this child develops or assumes an upright posture or normal vertebral posture, the curves will be changing from kyphosis to this particular lordotic curve. And as well as because of this change, the orientation of the facetal joint also will be changing. So they will be changing from your frontal plane alignment to the sagittal plane alignment. So that is the main reason why the motions in the lumbar region mainly predominated by your flexion and extension rather than your lateral flexion and rotation. So the orientation of facet in the lumbar region will be in the sagittal plane. So this is the biplanar orientation of the lumbar zygapophyseal faces. In this you can able to see the posterior aspect as well as the superior aspect. So in this you can able to see in the posterior aspect, you can able to see the orientation of this particular structure or orientation of this particular facets will be aligned in the sagittal plane. So mainly because of this orientation, so your flexion and extension will be predominated, and in the posterior aspect this will be aligned in the sagittal plane, and in the anterior aspect, so this is mainly aligned in the frontal plane. So in the superior view you can able to see here. So this is the posterior aspect and this is the anterior aspect. So the anterior aspect, it is mainly aligned in the frontal plane, and in the posterior aspect it is mainly aligned in the sagittal plane. So this is the biplanar orientation of the lumbar apophyseal joints. So the orientation of adult lumbar facetal joints display great variability both between individuals and within individuals. However, the majority of these joints have a curved structure that is biplanar in orientation. The anterior aspect of each joint remains in the frontal plane and the posterior aspect lies closer to or in the sagittal plane. The frontal plane orientation provides resistance to anterior shear that is present in the lordotic lumbar region. The sagittal plane orientation allows a greater range of flexion and extension motion and provides resistance to rotations. And coming to the ligaments and fascia, the majority of the ligaments associated with the lumbar region are the same ligaments that is of the other regions, such as your ligamentum flavum, posterior longitudinal ligament, anterior longitudinal ligament, interspinous and supraspinous ligament, as well as your apophyseal joint capsules. The supraspinous ligament is well developed only in the upper lumbar region and may terminate at L3 or third lumbar vertebrae, although the most common termination site appears to be the fourth lumbar vertebrae. The ligament is almost always absent at the L5-S1 junction, that is your lumbosacral junction. The deep layer of the supraspinous ligament is reinforced by tendinous fibers of the multifidus muscle. The middle fibers of the supraspinous ligament blend with the dorsal layer of the thoracolumbar fascia. The intertransverse ligaments are not true ligaments in the lumbar area and are replaced by your iliolumbar ligament at the L5. So the intertransverse ligament will be replaced by your iliolumbar ligament at the fifth lumbar vertebrae. The posterior longitudinal ligament is only a thin ribbon-like structure in the lumbar region, whereas the ligamentum flavum is thickened in the lumbar region. The interspinous ligament had the least overall stiffness and the joint capsule have the highest stiffness in the lumbar region. The anterior longitudinal ligament is strong and well developed in the lumbar region. So coming to the specific region or specific ligament that is present in the lumbar region, that is your iliolumbar ligament. The iliolumbar ligament consists of a series of bands that extends from the tips and borders of the transverse process of L5 to attach bilaterally on the iliac crest of the pelvis. So it will be starting from your transverse process of the L5 and they will be attaching bilaterally over the iliac crest or two-side iliac crest of the pelvic bone. So there are three primary bands for your iliolumbar ligaments, that is your ventral band or anterior band, a dorsal band or posterior band, and the sacral band. The ventral band or anterior band, which runs from the ventral caudal aspect of the transverse process of L5 to the ventral surface of the iliac crest. The dorsal or posterior band, which runs from the tip of the transverse process of L5 to the more cranial part of the iliac crest. And the sacral band, sometimes called the lumbosacral ligament, which runs from the ventral aspect of the transverse process of L5 to the ala of the sacrum and the anterior sacroiliac ligaments. So this is the iliolumbar ligaments. The iliolumbar ligaments as a whole are very strong and play a significant role in stabilizing the fifth lumbar vertebrae. The main function of this iliolumbar ligament are they play a significant or major role in stabilizing the fifth lumbar vertebrae, and they also are helpful in resisting the flexion, extension, and axial rotation, as well as your lateral flexion of the L5 on S1. The iliolumbar ligaments are maximally loaded at the lumbosacral junction in the absence of muscle protection against flexion when sitting in relaxed slouch posture. So during a person sitting in a slouch posture, the maximal load at the lumbosacral junction. So in this slouch posture, you can able to see the iliolumbar ligaments will be maximally loaded at the lumbosacral junction. And these ligaments can easily be a source of low back pain when subjected to creep in this position. So if the person is continuously sitting in this slouch posture manner, means definitely these ligaments will be getting stretched and this ligament will be getting weaker, and that may be the main source of low back pain. So coming to the next fascia, that is your thoracolumbar fascia, that is one of the ligamentous like structure present and protecting as well as stabilizing the lumbar region. The thoracolumbar region, also called as lumbodorsal fascia, consists of three layers, that is your posterior layer, middle layer, and anterior layer. The posterior layer is large, thick, and fibrous, and arises from the spinous process and the supraspinous ligament of the thoracic, lumbar, and sacral spines. So this posterior layer will be large, thick, and fibrous, and it will be arising from the spinous process and supraspinous ligaments of the thoracic, lumbar, and sacral vertebrae. So this is the anterior layer, middle layer, and the posterior layer. So posterior layer will be starting from the supraspinous ligament as well as your spinous process of the lumbar, sacral, and thoracic vertebrae. The posterior layer gives rise to the latissimus dorsi cranially and is continuous cranially with the inferior tendinous board of the splenius capitis and the lower fibers of the splenius cervicis. So this will be giving attachment to the latissimus dorsi superiorly and will be continuous with the tendinous border of the splenius capitis as well as your splenius cervicis. The posterior layer travels inferior caudally to the sacrum and ilium and blends with the fascia of the contralateral gluteus maximus. This particular thoracolumbar fascia will be attaching superiorly over the latissimus dorsi and the tendinous portion of your splenius capitis as well as splenius cervicis, and inferiorly it will be getting attached over the sacrum and ilium, and this will be blending or mix up with the fascia of the contralateral or opposite side gluteus maximus. The deep fibers are continuous with the sacrotuberous ligaments and connected to the posterior superior iliac spine, iliac crest, and long posterior sacroiliac ligaments. The posterior layer deep fibers will be continuing with the sacrotuberous ligament, and they will be connecting to the posterior superior iliac spine, iliac crest, and the long posterior sacroiliac ligaments. The posterior layer also travels laterally over the rectus spinae muscles and forms the lateral raphe and at the lateral aspect of the rectus spinae. So it attaches superiorly, it attaches inferiorly, and it attaches laterally also. So laterally it will be attaching over your rectus spinae muscles, and they will be forming the lateral raphe. So this is the posterior layer, this is the middle layer, and this is the anterior layer. So this particular fascia will be attaching, the posterior layer will be attaching over the lateral aspect of the rectus spine and forming the lateral raphe. So the internal abdominal oblique and the transverse abdominal muscles arises from the lateral raphe. The posterior layer becomes the middle layer and travels medially again along the anterior surface of the rectus spinae and attaches back to the transverse process and intertransverse ligaments of the lumbar spine. The posterior layer will be becoming the middle layer in the medial aspect, and so they will be giving attachment to the transverse process in the transverse process as well as the intertransverse ligament of the lumbar spine. These two layers completely surround the lumbar extensor muscle group. The anterior layer of the thoracolumbar fascia is derived from the fascia of the quadratus lumborum muscles, where it joins with the middle layer, inserts in the transverse process of the lumbar spine, and blends with the intertransverse ligament. So the anterior layer will be blending with the middle layer, or it will be joining with the middle layer, and this anterior layer will be inserting over the transverse process of the lumbar spine, and it will be blending with the intertransverse ligaments. So this anterior layer is derived from the quadratus lumborum muscle fascia. The thoracolumbar fascia acts as a stabilizing corset by demonstrating that the fascia increases the spinal stiffness. So this particular thoracolumbar fascia will be acting like a stabilizing corset, and this will be increasing the spinal stiffness and protecting the particular structure over the lumbar region as well as your thoracic region. So this thoracolumbar fascia tightness may lead to back pain. The function of the lumbar region. So first is your kinematics. The lumbar region is capable of movement in flexion, extension, lateral flexion, and rotation. The lumbar zygapophyseal facets favor flexion and extension because of the predominant sagittal plane orientation. So I already told you many times, because of the orientation of the facet in the sagittal plane, the main movement will be your flexion and extension. The amount of flexion varies at each interspace of the lumbar vertebrae, but the most of the flexion take place at the lumbosacral joint. So the lumbosacral joint is mainly responsible for the most of the flexion movement taking place in the lumbar region. So this is the thoracolumbar flexion, as I already discussed thoracic kinematics in the previous video. So in this video, we will be explaining in detail about the kinetics and kinematics of your lumbar region. So in total, you can able to see thoracolumbar flexion will be 85 degrees, and in this 35 degrees of flexion will be happening in the thoracic region, and remaining 50 degrees of flexion will be happening in the lumbar region. So in this, during thoracolumbar flexion, during flexion of the lumbar spine, one of the things that is happened is here sliding of one vertebrae over the another vertebrae, and the anterior annulus fibrosus will be getting compressed and bulging anteriorly, and the posterior annulus fibrosus will be getting stretched, as well as your remaining the posterior ligaments. So the during flexion, your anterior longitudinal ligament will be getting compressed, and your posterior longitudinal ligament, interspinous ligament, supraspinous ligament, and your other ligaments over your posterior region, as well as your joint capsules will be getting stretched. And because of this stretch happening at these particular posterior ligaments, the excessive flexion or hyperflexion will be prevented by these particular structures. So this is the kinematics of your lumbar spine in flexion. So coming to the thoracolumbar extension. So in total, you can able to see there will be 35 degrees of extension happening in the both thoracolumbar region, and in which the extension will be around 15 degrees in the lumbar region. So during extension, what are the things or what are the kinematics happening during the lumbar extension are your anterior longitudinal ligament will be getting stretched, and your posterior longitudinal ligament along with your other ligaments will be getting slacked, as well as there will be a bony contact between two spinous processes, and that is known as your bony approximation, and this will be preventing the hyperextension or excessive extension happening in the lumbar region. As well as during extension of your lumbar spine, there will be inferior sliding of one vertebra over the another vertebrae. So this is about the kinematics of your lumbar spine extension. So next is about the axial rotation or rotation happening at the lumbar region. So during rotation, there will be sliding of one vertebra over the another vertebrae. So during rotation towards your right, there will be sliding of one vertebrae over the another vertebrae in the left. So opposite side sliding will be happening. So this is about so in this around 40 degrees of rotation happening in the thoracolumbar region. So in this thoracolumbar region, around 35 degrees of rotation will be happening in the thoracic region, and just 5 degrees of rotation will be happening in the lumbar region. So coming to the lateral flexion, thoracolumbar flexion, lateral flexion will be 45 degrees, and 25 degrees will be happening in the thoracic region, and remaining 20 degree will be happening in the lumbar region. So during lumbar lateral flexion, there will be sliding. So if the person is laterally flexing towards the right side, there will be inferior sliding of the same side vertebrae and superior sliding of the opposite side vertebrae. The right side facet will be sliding inferiorly, and the left side facets will be sliding superiorly. So this is what happens during the lateral flexion towards the right side. So during this lateral flexion, the opposite side ligaments as well as the opposite side muscles will be getting stretched. The intertransverse ligament on the opposite side. So if the person is laterally flexing towards the right side, the intertransverse ligament of the left side will be stretching, and as well as the other muscles that is over the lateral aspect of the spine will be preventing the excessive lateral flexion. And the intertransverse ligament of the same side, that is the right side, will be getting compressed, as well as your other muscles also will be getting compressed during this particular lateral flexion movements towards the right side. So this is what happening during the lateral flexion, as well as the anterior annulus, the annulus fibros in the same side, that is the right side, will be getting compressed and bulging, and the opposite side, that is the contralateral annulus fibros, will be getting stretched and preventing the excessive motions. The lateral flexion and rotation are most free in the upper lumbar region and progressively diminish in the lower region. The largest lateral flexion range of motion and axial rotation occurs between the L2 and L3. In the lumbar region, the coupled motions usually occur with lateral flexion and axial rotations. Hip motion eliminates the need for full lumbar flexion, which would serve as a protective function by protecting the annulus fibrosis and posterior ligaments from being fully lengthened. The contribution of motion from multiple areas to produce a larger range of motion than could be accomplished by a single area is similar to what is found at the shoulder, that is your scapulo-humeral rhythm. So there is one rhythm in the shoulder that is known as scapulo-humeral rhythm. That is mainly because of the combined motions of your shoulder joint as well as your scapulothoracic joint. So similarly, there is another rhythm or combined motions that is occurring in the lumbopelvic region, that is known as your lumbopelvic rhythm. A restriction of motion at either the lumbar spine or at the hip joints may disturb this rhythm and prevent a person from reaching the toes. Restrictions of motion at one segment may result in hypermobility of the unrestricted segment. So there will be some compensatory motions that is happening in order to complete or maintain this particular lumbopelvic rhythm. So one motion is restricting means the other structure will be, or the other segment will be compensating for this particular completion of the task, and finally leads to hypermobility of that particular segment, which is giving or compensating. So this is the normal lumbar and hip flexion. This is the normal lumbopelvic rhythm, and these two are the altered lumbopelvic rhythm. So in this normal lumbar flexion and the hip flexion will be happening, and both this flexion will be contributing the normal pelvic rhythm. And so you can able to see the normal kinematic strategy used to flex the trunk from standing position incorporate a nearly simultaneous 45 degrees of flexion in the lumbar spine and 60 degrees of flexion in the hip or hip joint. So 45 in the normal lumbopelvic rhythm, there will be 45 degrees of flexion in the lumbar region and 60 degrees of flexion in the hip region. So if the person have limited flexion of the hip, so greater flexion is required in the lumbar region. So if the person is having some issues or pain in the hip joint means, so apart from the normal 45 degrees of lumbar flexion, they need to compensate or they need to move more. So there will be greater than 45 degrees of flexion happening in the lumbar region. So that is hypermobility over the lumbar region will be occurring. So this is what compensation means. So if the person is having limited hip flexion means the other structure, that is the lumbar region, need to compensate in order to achieve or accomplish this particular task of touching the toe. So next scenario is if there is limited or restricted range of motion in the lumbar region, that is less than 45 degrees in the lumbar region, means the hip joint need to compensate. The hip flexors need to compensate more. So this is the another scenario. So during the limited lumbar flexion with excessive hip flexion. So this is the three variations. First one is the normal lumbopelvic rhythm, and remaining two are the altered pelvic rhythm, where one joint's range of motion is restricted means the other joint will be compensating for this particular task in order to achieve this particular task. So coming to the kinetics, the first one is your compression or axial compression. One of the primary functions of the lumbar region is to provide support for the weight of the upper body of the body in static as well as dynamic situations. The increased size of the lumbar vertebral bodies and disc in comparison with other regions help the lumbar structures support the additional weight. The lumbar region must also withstand the tremendous compressive loads produced by the muscle contraction. So the compressive force is mainly because of the structures, mainly because of the structures that is located superior, that is your weight of the head, cervical region, and as well as your thoracic region. Apart from this compressive force, there will be compressive load because of the muscular contraction that is present over the lumbar region also. The lumbar interbody joints share 80% of the load, and the facetal joints in axial compression will be sharing 20% of the load. So during axial compression, 80% of the weight bearing will be happening in the interbody joints, and remaining 20% will be happening in the facetal joints. This percentage can change with the altered mechanism. So if the person is having any issues or degeneration occurring in the interbody joints, so this will be becoming, the interbody joints load will be becoming 20% and the facetal joint will be becoming 80%. So vice versa, almost exactly opposite it will be happening, and it may lead to your another degeneration of your facetal joints. Now this is what happening during your aging process because of the mainly because of the degeneration of your intervertebral disc. With increased extension or lordosis, the zygapophyseal joints will assume more of the compressive load. Also, with degeneration of intervertebral disc, the zygapophyseal joints will assume an increased compressive load. So lumbosacral loads in the erect standing posture were in the range of 0.82 to 1.18 times the body weight, while lumbosacral loads during level walking were in the range of 1.41 to 2.7 times the body weight. That is an increase of 56.3%. So normal erect standing, the lumbosacral load will be almost 0.82 to 1.18 times the body weight, and the lumbosacral load will be increased almost to 56.3% during the level walking. So changes in the position of the body will change the location of body's line of gravity and thus change the forces acting on the lumbar spine. So next kinetics is your shearing force. In the upright standing position, the lumbar segments are subjected to anterior shearing force caused by the lordotic position, the body weight, and the ground reaction force. The anterior shear or translation of the vertebrae is resisted by the direct impact of the inferior faces of the cranial vertebrae or the superior vertebrae against the superior faces of the inferior or the subadjacent vertebrae. It depends on the extent to which the inferior vertebrae's superior faces lie in the frontal plane and facing posteriorly. The more the superior faces of the caudal vertebrae faces posteriorly means the greater the resistance they are able to provide to forward displacement, because posteriorly faces lock against the inferior faces of the cranial or superior vertebrae. So if the superior facet is facing, superior facet of the inferior faces, inferior vertebrae are facing posteriorly means, so it can able to prevent the excessive anterior displacement or anterior shearing forces, because of the more posterior location of this inferior vertebrae, they will be articulating or they will be locking the inferior faces of the superior vertebrae. So because of the interlocking mechanism, it can able to prevent the excessive anterior shearing forces or forward displacement of the vertebrae. So this is the shearing forces that is happening at the lumbosacral joints. The maximum shearing force that will be happening in the lumbosacral junction. So in this you can able to see the anterior shearing component. So this is the normal comparison between the normal lumbosacral angle and the increased lumbosacral angle. So during normal lumbosacral angle, so the body weight acting on the L5 will be resulting in a L5 having a both compressive force, resulting in a both compressive force as well as the shearing force. So there are two components, that is FOS, that is your anterior shearing component, and FC, that is your force of compression, that is the compression component. And the resultant vector mainly, so because of the body weight, you can able to see a parallelogram. So in this, the body weight will be passing through this particular region. And with an increased lumbosacral angle of 45 degrees. So if this is the normal 30 degrees lumbosacral angle, and if the lumbosacral angle is increased to 45 degrees, so there will be an increase in the anterior shearing component. So you can able to see here, the force of the body weight acting on the L5 results in a shearing force that is equal to or greater than the compressive force. So it may lead to an increased anterior shearing force because of the increased lumbosacral angle. So if the lumbosacral angle is increased, means there will be an increased anterior shearing force. So this mainly happen or occurs due to the slouch posture. So this is all about the shearing forces or shearing stresses that is happening in the both your normal lumbosacral angle and your increased lumbosacral angle. So by this, we are concluding the kinetics and kinematics of your lumbar spine. In the next video, we'll be discussing in detail about the kinetics and kinematics of the sacral region. Please do subscribe and share this video to your friends and physio fraternity. Thank you.